We had looked at this diagram when we looked at dorsal rami. Remember the innervation of the deep muscles of the back? But this time we're going to look at ventral rami. Okay? So we looked at it on Tuesday when we were discussing the dorsal rami innervating the rectus spinae and splenius capitis coming out here from the dorsal rami. But now let's follow the ventral rami. These are passing between the intercostal muscles. And remember I talked about a plexus, the cervical plexus and the brachial plexus and so on. The thoracic nerves, or the ventral rami, are the only ones that don't form a plexus. So from T2, T3, T4, T5, T2 through T12, the ventral rami run in between each of the ribs and innervates the muscles, the intercostal muscles that we find between them. So there is no blending or interweaving together. So that's the intercostal nerves that we're going to be talking about. The other muscle of respiration is the diaphragm. This is the cervical plexus, and here would be the ansa cervicalis, right here. Okay. Coming from ventral rami C3, C4, and C5, we have the phrenic nerve. And we can see that in the cadaver today. The phrenic nerve comes into the neck all the way down either side of the heart to the diaphragm. So if a person fractures their neck and damages, creates a lesion of the spinal cord above C3, they're going to need to be on a ventilator. Someone like Christopher Reeves, who was thrown from his horse and was paralyzed. Now he did develop the ability when he was awake of consciously taking a breath. If you saw him speaking, he would do that. He'd take a breath and then kind of talk with that air. But when he went to bed, he had to be put on a ventilator because he didn't have the reflex activating the phrenic nerve. So his damage was probably slightly, maybe part of C3 might have been still available, but not all of it. So those are the two nerves involved with our muscles of the chest for respiration. Okay. So the function of the intercostal muscles is to move the ribs. They go from rib to rib either as an internal intercostal or an external intercostal. And the ribs, if you can look at the articulated skeleton, have a slight downward orientation. So when we lift up the ribs just a little bit, we're increasing the distance from front to back of the thoracic cavity. When we change that, we increase the volume of the thoracic cavity. And what happens to pressure if you change volume and keep the number of particles the same? Yes, pressure drops. All right, so if you were to just open your mouth, you're not doing anything, just open your mouth, air's not going anywhere. All right, but if you lower your diaphragm and lift your ribs, then you've increased the volume, and atmospheric pressure is now higher than intrathoracic pressure, and it pushes air into your lungs. So that's what the external intercostals are going to do. I'm going to draw the internal intercostals first, just so I can overlay them. The internal intercostals do the reverse. Typically, if I take a deep breath and then let the air out, you didn't use any muscles, active contraction of any muscles to let that air out. It was passive relaxation of the ribs, the muscles that lifted the ribs. However, if you're going to blow up a balloon, you start using it and feel your abdominal muscles contracting as they compress the abdominal cavity and push the diaphragm up. And you can use these internal intercostal muscles to pull the ribs down. All right? So internal intercostal muscles function in expiration. So they're going to pull the ribs down, and their origin is the superior surface, or the top surface of the bottom rib. So origin is from this area up to here. So remember, origin is the immovable point of attachment, and insertion is the movable. So our muscles are oriented in this direction, wrapping all the way around to the vertebra, they stop about 2 inches before they get to the vertebra. So this is the pattern for internal intercostals. Origin is the inferior, insertion is the superior. Notice that the two sides create a pattern like this, so an inverted V. If I grab and pull down, this is what they're doing. They're pulling the ribs down. Okay? For active expiration. We don't use these every time we take a breath. We just use them when we're trying to force air out at a faster rate. So these are the internal intercostals. Active expiration. Typically expiration is passive. They be throughout the ribs. I've just drawn a part of them. Now, the external intercostals are what we use every time we take a breath, along with the diaphragm. So they have these attachments reversed. Their origin is going to be the superior rib, its inferior surface, and the insertion is going to be the inferior rib, the superior surface. So they go down and grab. So if internal intercostals are doing this, external intercostals are doing this. Okay? So they form a V pattern when you look at right and left together. So they actually start about 1 to 2 inches lateral from the sternum, so we can see the internal intercostals as they overlap them. Just on either side. Okay. So those are the external intercostals. This is for just anytime we take a breath in for inspiration. There is a third layer that's deeper, but we're not going to worry about those. There's only a partial remnant of them anyway. Okay? So you can see these on the what we call the breastplate, the front chest and abdominal covering, on our small model here, and also on this one. All right, so here are the internal intercostals, and then you can see a little bit of the external intercostals here, going in the V pattern if we use both of them together. And let me turn the lights down here. Okay, so internal intercostals are here, covered up by the epimysium of their muscle, and here would be external intercostals. So the external intercostals don't go all the way to the sternum, and so we can still see some of the internal intercostals. All right, the other muscle of inspiration is the diaphragm. It's a highly domed muscle. I'm not going to draw it on the board, but it has most of its origin is off of the lower ribs. So we're looking up from the abdominal cavity onto the inferior surface of the diaphragm. There are a couple of slips here that come from the lumbar vertebra. And the insertion is not to bone, but to this broad white region called the central tendon. A similar tissue to the Galea aponeurotica that we saw over the top of the skull. Okay? And so that's the central tendon. There's an opening for the inferior vena cava, one for the esophagus looking down on the top. This is where the heart would sit, and here's the central tendon. So the fibers have their origin and pass medially into the central tendon. So it's very domed, and when it contracts, it flattens out. When you breathe in, the diaphragm becomes lowered, so you increase the vertical distance, increasing the overall thoracic cavity volume. And then when you breathe out, the diaphragm raises, decreases the volume of the thoracic cavity, and causes the atmospheric pressure to become increased. So this is a model of the diaphragm. Okay? So this edge would be attached to the vertebra, to the ribs. And here are those two slips that come from the lumbar vertebra, and opening for the inferior vena cava, and it fits like this. Like that. So it goes up quite high underneath the ribs. The ribs will be coming down to here. You can see that it's 2 or 3 inches up into the thoracic cavity. Okay? I read once about a woman who, back in the 30s or so, had developed tuberculosis. And it was very bad. It's a bacterial infection of the lung. She was sent off to a sanitarium. And they tried a variety. One of the things they did to isolate the region of infection was to inject air into the abdomen and kind of push the diaphragm up, and I helped to isolate off the area of the lung that was infected. That didn't work for her. She was dying. She asked permission if she could come home to spend Christmas with her family. And they said yes, but you need to wear a mask while you're home and everything. So she did. Spent Christmas with her family. Came back pregnant. And it's like, what a cat. You know, his wife is dying and he can't leave her alone. Anyway, so she got better. The baby cured her. Because as the baby grew in fetal development, the uterus rises up into the abdominal cavity and it pushed up on her diaphragm and helped to collapse that area of the lung and compress it and help the tubercular bacillus to get walled off and allow the body a chance to heal, where the drugs in that attempt by the physicians hadn't worked. And she was able to recover and go home. Sorry guys, I'm sure one of the reasons she wanted to go home was to see her husband. But it was just like, here's this poor sick woman. So diaphragm increases superior-inferior diameter, and intercostals affect the anterior-posterior diameter. Alrighty? Now those are actual muscles of respiration, either inspiration or expiration. We're going to look at muscles that function as accessory respiratory muscles. So we've already talked about one, and that was the sternocleidomastoid. So remember, the normal insertion of the sternocleidomastoid is the mastoid process, and it functions to turn the head or to flex the vertebra. However, if we use the splenius capitis and semispinalis to keep the head from being flexed, keep it from being moved, and then contract sternocleidomastoid, it will help to lift up the sternum and clavicle and help you take in a slightly deeper breath if you are up in higher altitude, trying to take a deeper breath. So that we call that an accessory. Its normal function is not to aid in breathing, but by changing organ insertion, we can help it move the ribs. All right, so let's now go back to page 21. Most of them will be in the back region, but we'll also look at the pectoralis minor. These are considered to be superficial and intermediate muscles of the back. They do not cause the upper extremity to move. Okay? The next 4 or 5 muscles that we're going to talk about all function they all attach to the scapula. And so they're going to stabilize the scapula, they're going to tilt it up or down, or keep it pulled up against the rib cage. So we're on page 21. All right? So let me draw the posterior view here. So if any of these muscles is paralyzed or doesn't work, it's not going to affect the movement, in the sense it's not going to keep the upper limb from moving, because it doesn't cross that joint. So as you're studying these muscles, pay attention, again, to what joint does it cross. And that's where you're going to see its action. Okay? So give me a few moments here to diagram this in. And just kind of diagrammatically representing the vertebrae here. a posterior view. And the first muscle we're going to talk about is the trapezius. So the trapezius, now when you look at diagrams or you look at our models, pay attention to what you're seeing. You can see that on this view you don't see a trapezius. So this is considered to be the superficial view. And then once we take off the trapezius, we can see the next layer, the intermediate layer. Okay? Same thing on the models. So just take a moment and say, okay, I'm looking at the back, I'm looking at a superficial or a deep dissection, or I'm looking at the upper limb, I'm in the posterior forearm, and that can help you figure out, if you're in the posterior forearm, you're going to be doing extension, not flexion. Okay, so just a few moments to orient yourself to what part of the body you're looking at, what region, can help eliminate some quick answers that you go, what in the world was I thinking? It's because you weren't paying, hadn't taken a moment to pay attention to where you were. So the trapezius has its origin from the spinous processes of the vertebra. You'll notice that some of the fibers come down to their insertion, some of the fibers come up to their insertion. And that's going to affect what the muscle does. Now, that also will attach to the clavicle. So if I put the clavicle in here, fibers will attach to the clavicle as well as to the spine. So they kind of form a curve. All right. So if we look at this model of the upper extremity here, here's the posterior view with the scapula. This would be the spine of the scapula. Here's the clavicle. So these cut fibers right here belong to the trapezius. So it wraps around from the front as well as attaches to the back. So you'll see a slight portion of the trapezius on the anterior aspect of the neck. So when you look at the small model back here, you're seeing a little bit of trapezius right here, okay, as well as all the way around the back. And deltoid is going to do the same thing from below. So we have a similarity to that pattern. So my neck is a little bit short here on my diagram, but we'll deal with it. So fibers from the spinous process are going to come and attach to the clavicle and attach to the spine. All right, so these fibers of the trapezius are going to function to elevate or lift the shoulder blade, the scapula. Okay? You're going to pull it up. Then we have other fibers from the thoracic spinous processes which are going to insert from below. So these are going to depress the scapula. So the same muscle is antagonistic to itself. It can lift the scapula up, it can depress the scapula down. And then we also have fibers that are more horizontal. So the two muscles together create this trapezoid appearance from which we get that name. So the fibers that are more horizontal are going to pull the shoulders back. So you know that movie with Reese Witherspoon, Legally Blonde, and she teaches the
Ben and Snap.
yeah. Oh yeah. They're using this one as well as the deeper muscle. So I want you to think of that. I'm going to ruin this movie for you. Say, I know the name of that muscle. She teaches the hairdresser who's in love with the UPS delivery that to get him to notice her, drop a pencil or whatever, and you pick it up and then you do this and pop out your assets. Okay, so that's trapezius. Elevate, depress, and retract the shoulders. All right? Then also coming from the vertebra, this time more from the transverse processes, and going just to the superior angle of the scapula, we have the levator scapulae, and that's this muscle right here. Okay, so it comes down this fashion and attaches just to the corner. So if it attaches here, okay, it's going to lift it, but it's also, without any other influence, it's going to tilt it downward. It's going to rotate the scapula downward. And so this is called the levator scapulae. Now, deep to the trapezius, we have a pair of muscles, the rhomboideus minor and major, that also keep the scapula attached. Remember, the scapula doesn't have any ligaments that attach it to the torso. It's attached by the clavicle here to the sternum, and that's it. So these muscles become very important in keeping the position of the scapula. So the rhomboideus muscles will also help to keep the scapula flattened or protracted up against the ribs. And we have two sets, from vertebra to medial border. We have the rhomboideus minor, and then there's a small gap, and again we have another muscle, same name, that runs down the rest of the scapula, and that's rhomboideus major. Okay, and I don't really, you don't have to differentiate between them. Yeah. So. And these are found deep to the trapezius. You might see a little bit of it in a little small corner there, but usually not very much. Okay, the next one also keeps the scapula pulled up against the ribs, and it's called the serratus anterior. It actually has two parts. The part that is attached to the scapula is very thick and meaty, whereas the part that we see laterally and anteriorly is attached to just the ribs, and it gives us the serrated or knife edge-like appearance. It's actually attached to all of the ribs underneath this muscle. So if we come back to this breastplate here, you can see these muscles right here. See how there's individual slits going to the rib, not between the rib. If it's between the rib, that's the intercostals. But going to the rib is the origin of serratus anterior. So if I put it in place, I have to hold it here because there's no hook to attach to the eye. You can see how it's coming around the side here. There are these slips, okay, and they all come together and attach or insert onto the deep surface of the inferior angle right here. It could be about 1.5 inches thick at this point. So that's its meaty portion. And so, again, there's the origins here, so insertion is to pull the scapula up, just kind of tighten, kind of think about, you just put your hands there, just kind of tighten, and you can feel the scapula kind of pull up against the ribs. Okay? So that's the serratus anterior. Its insertion, as you can see here, are the ribs, and then from there, it's going to swing around and attach to the anterior surface. We can see that on the cadavers. I'm going to pull the scapula forward. This is another one, another muscle that can be an accessory respiratory muscle, because its origin is the ribs and its insertion is the scapula. Now if we fixate the scapula, not allow it to move, then we can lift up the ribs and reverse attachments. So this can become an accessory muscle for inspiration by stabilizing the scapula, making the origin the scapula and the insertion the ribs. We can help to lift up the ribs slightly. So it becomes an accessory muscle of inspiration. The last muscle is from the front. All right. So I'm going to draw it up here. Put in our sternum again. I won't bother with the cartilage. And then we have the scapula. So this is an anterior view. Here would be our coracoid process. And so this last muscle, pectoralis minor, has its origin from ribs 3, 4, and 5 and inserts onto the coracoid process of the scapula. So it's a small triangular muscle. And that's pectoralis minor. Okay, I'll show it to you on the breastplate again. If you were to pledge allegiance, okay, put your palm on your ribs, and you can feel the coracoid process right here. That's the position of pectoralis minor. So when you push your shoulder forward, you can feel that muscle contract as that coracoid process passes forward. So if we use the articulated skeleton here, right, it would be doing this, or that. So origin is here, insertion, the coracoid process right here. Okay. Now this is a pectoralis minor, and yes, there is a pectoralis major, but in this case they do entirely separate things. Pectoralis minor inserts onto the scapula and moves the scapula. Pectoralis major inserts onto the humerus and moves the arm. Also, pec major is superficial to pec minor. So let me put this, actually you can see it best if I put it on the model itself. So here are the muscle fibers of pectoralis minor. And here's insertion onto the coracoid process. Okay, so it's going to pull that scapula forward. You'll notice none of these muscles actually inserted onto any bones of the upper extremity. They insert onto the scapula. So they are going to stabilize or move the scapula. All right. Let's look, and we'll finish up with muscles that go from the scapula to the arm. Okay? And then on Thursday, we'll finish the arm and do the abdomen. So we don't have, this is pectoralis major, and pectoralis minor is under that. So here's pec major, here's pec minor under the fascia that's going to the coracoid process. So now we're going to look at these muscles, right? And these muscles have their origin from the scapula. All of them are going to have their origin from the scapula and cross the shoulder joint. So it's going to depend, what they do is going to depend on whether they cross the shoulder joint from the back, from the front, or down the side. So rather than just memorizing from cold what these do, you draw them on yourself or draw them on the board and then do the movement, then it makes sense if you understand what their attachments are. All right, so I want to erase the board. You guys okay with that?
got another one of the sheets. And like this is skeleton. So we'll make flashcards of all the muscles, and then we'll draw them on like the skeleton. And then we'll have
Page 27 is the pictures, and page 29 the muscles. Pardon?
say it's going to be on film.
Page 25 is a list of the muscles in the various compartments of the arm, but we won't look at that till Thursday. Because we're just outside the arm. We're not actually within the upper appendage. All right, so before I erase this board, I want to add pec major. So pectoralis major, unlike our other minor major components, is actually, here, is actually superficial pec minor. Okay, all our other minors and majors, minor was above and major was below. Now it's the major is superficial. So pectoralis major is actually going to attach to the humerus. It crosses the shoulder joint. It doesn't come from the scapula like all of our other muscles, but it comes from the sternum, and it comes from a little bit from the clavicle. So we have two heads. They aren't called different heads, but it makes it almost look like two different muscles. And then it comes up and covers pec minor like this, but it causes it attaches to the shaft of the humerus here. So that is pec major. So because it crosses the shoulder from the front, all right, if you think about what it's doing, it's going to pull the humerus across the front of the arm, chest. So what do we call that movement? Moving a part of the body closer to the midline. Adduction, adducting, okay? I say AD just to clarify whether I'm saying adducting or abducting. So adduction, and it also can pull the humerus forward this way, and that is flexion. So flexion is decreasing the angle. Right now the angle of the upper extremity is 180 degrees. Now it's 90, okay? Or it's 0 degrees, 90. So we're decreasing the angle, we're flexing, all right? So adduction and flexion of the shoulder joint. Now let's look at muscles from the posterior view of the scapula, and those are on these models of the upper limb. So we're going to start using some bony processes that you may remember, hopefully you'll remember, from the bones. Supraspinous fossa, infraspinous fossa are going to be our origins, and our insertion is going to be the lateral, the greater tubercle, which is lateral, and the anterior tubercle, my terms are here. The greater tubercle, which is lateral, and the lesser tubercle, which is anterior. And those are going to be our attachments for these muscles. All right, I'll leave that pectoralis major up on the board, and I'm going to erase this one here. Actually, no, I'll leave this up here and erase pec major. So if you want pec major, take a picture of it. I'll just use the scapula here on the side. Right on this side. So greater tubercle, and may I erase this now? So I'll put in our so from the back, first one we're going to look at is the deltoid. And the deltoid, if you recall, has the same origin as the trapezius, has it for its insertion. So the clavicle and spine are the insertion for the trapezius. For the deltoid, they're going to be its origin. The deltoid has this shape. So this would be where it has its origin from the clavicle, and this would be where it has its origin from the spine, and fits like this. Okay. So if it crosses the shoulder joint from the front, these fibers right here are going to be able to do abduction. If it crosses the shoulder from the back, flexion. They're going to be able to do flexion. If it crosses from the back, it's going to be able to do extension. But by far, the majority of the fibers are coming over the lateral aspect to attach to the deltoid tuberosity and do abduction. Okay? So those are the three major functions: flexion, abduction, and extension. And we put all that together, we can kind of do a circumduction as well. So I'm going to draw that one on this side here, where we have this is the posterior view. So we have these fibers of deltoid crossing over the shoulder joint and coming down and attaching to the deltoid tuberosity, forming this cap. And this is the deltoid muscle. Deltoid is innervated by the axillary nerve. And we'll talk about that in more detail on Thursday when we look at the brachial plexus. That would be this one here. Okay, from the front and from the back. Right here. Now let's take that off and take off the trapezius and start with we're going to look at these 3-4 muscles right here. Okay. We have those and one from the front, and then we'll be done. Do that. So coming from the supraspinous fossa at a horizontal direction, we have the supraspinatus muscle. So it's going to come over and attach to the greater tubercle. And so this muscle is very horizontal in its orientation. This is the, again, not the supraspinous, but supraspinatus muscle. And it also functions, well, you just usually do it. It also functions in abduction. Deltoid would be the agonist. Supraspinatus is the synergist. Now, if you look at the fibers of deltoid, they go almost straight down, where they are lateral to the humerus. So if we use them by themselves, then we try to do abduction. So I'm not going to use the supraspinatus. I'm just going to use deltoid to try to do abduction. What's going to happen is it's going to pull the humerus straight up, because that's the angle at which those fibers are oriented. For the deltoid to work best in abduction, it needs to start from an angle about 30 degrees. And that's what the supraspinatus does. All right, so the supraspinatus pulls the humerus out, abducts the humerus out about 30 degrees, and now the deltoid can work to do this. So some people, the nerve to the supraspinatus can be damaged. It crosses the neckline right here. And so they may have that muscle paralyzed. And so what they do to get around it is they just drop their shoulders. If they want to brush their hair, they can't lift their arm up, but the deltoid works perfectly fine. They drop their shoulder like this, that creates that gap, and now the deltoid can work and they can brush their hair. So they kind of get around it by that. It's a little bit of behavioral math modification. Okay? So supraspinatus, abductor. Now below the spine, this whole process is called the infraspinous fossa. So that muscle is this one that you see right here. All of this. It looks like multiple muscles, but all of that is infraspinatus. Okay. It also attaches to the greater tubercle. So infraspinatus, its major function is lateral rotation, sometimes called external rotation. This is what I'm doing with my humerus, all right? So it's laterally or externally rotating. If I'm the humerus and me is over there, okay? So that midline would be over there. I'm rotating away. The entire bone rotates. That's lateral rotation. Right? So Mona, can you come and be my humorist for a moment? So now I'm going to be the infraspinatus muscle. Simona is the humerus. All right, so I start over here, coming off the scapula. My fibers extend out, grab onto the greater tubercle, and when I pull, I turn the humerus. Lateral rotation. Okay, and that, thank you. You better not miss that. You're going to have that muscle memory. So that's infraspinatus. Because it's coming from the back, it can also do extension, but its major function is lateral rotation. Then we have a small muscle that does the same thing. It's seen right here. Origin is the lateral border of the scapula, so right along the edge, but still inserts onto the greater tubercle. Teres means round. So here's another major minor, only this one also does something different. So that's teres minor. It's going to do the same thing as infraspinatus, but it's a smaller muscle, so not as strong. So it's also going to do lateral rotation. These three muscles, supraspinatus, infraspinatus, and teres minor, are all part of a group of 4 muscles identified as the rotator cuff muscles. If you've followed sports, you've probably heard of someone who has a torn rotator cuff. So these tendons provide an extra support for the shoulder joint. We have the synovial capsule, we have the ligaments of the shoulder we learned about, the coracoacromion and so on, and then superficial to those, we have these tendons. And they spell the word sits. So far, we just have the S and the I and the T. Okay, the S comes from a muscle on the anterior surface. We'll get to in just a moment. It'll be the last muscle we talk about. So here's supraspinatus, here's infraspinatus, and right here is teres minor. Okay, and then on the anterior surface, remember this was the subscapular fossa? This is the subscapularis muscle. And it's the 4th one of our rotator cuff. But before we get to the anterior surface, let's talk about this last muscle from the posterior surface, teres major. It does medial rotation. So Simona, I need you one more time. So remember, she's the humerus, okay? And as the infraspinatus and teres minor, I'm grabbing onto the greater tubercle and doing external or lateral rotation. Okay, teres major still starts from the scapula, but instead of going posterior, it comes around the front of the humerus, grabs the lesser, and does medial rotation. Okay, the others did lateral because they came around the back. Teres major comes around the front and does medial. You dizzy yet? No, I'm fine. Okay? So while it looks as a similar muscle, it's going to come around from the front and turn it into the body. So it does medial rotation. So it's going to be a bigger muscle. It's going to come here. And then it's going to go to the front of the humerus to the lesser tubercle. And that means the dotted line is just passing around it. So that is, there's a gap between the two. I'll show you in just a moment. So this is teres major. It's not part of the rotator cuff. Now, to help you identify these two, on Thursday we're going to be talking about the compartments and the triceps brachii. Triceps means 3. So only one head of the triceps brachii actually crosses the shoulder joint. The others only cross the elbow joint. And this head splits teres minor from teres major. So you can use it to help you identify those two. You can use those two to help you identify this head of the triceps brachii. All right, the last muscle then, I'm not going to bother to diagram it, is subscapularis. It's on the anterior surface of the scapula. Actually, I think I'll do, yeah, I have latissimus dorsi. I'll do that one, this will be second to last. So it also, like the triceps teres major, attaches to the end, the lesser tubercle